So yesterday we looked at all of these different fetal heart rate tracings along with the maternal contractions that were occurring. We learned about the different heart rates. We learned about the different types of decelerations you can have, which were basically decreases in the fetal heart rate, sometimes related to the maternal contractions. So this first one here, this is the variable deceleration, which was one of the easiest ones to identify. I feel like this image here does a good job showing you why it's easy to identify, because it's such a tiny V. Right, so the deceleration is a very tiny V. Compare that to this massive U that you get here, right? Which is, in this one is early deceleration. This one is a late deceleration, which also has a pretty big U. Right, so both of those big U's indicate that it's more than 30 seconds ever since the onset to basically the nadir, right? So that's what we're really looking at. Remember that you can get graphs of all kinds. For example, this graph, the one that they have in first aid, is terrible because all they're showing you in the first aid graph is the heart rate. And we saw earlier that the normal heart rate is 110 to 160, so it should be between here to here, right? And you can see that some of these decelerations are going under, right? But never does it go over the 160, okay? But we can't see the minute lines. Remember, there were lines to show you how long is a minute. That is not on this graph, right? So nor is it really in this graph. Right? It's not in this one here either, the U world one. But sorry, the U world one. But this U world one, this one has it. Right? So this one shows it to you very nicely. These vertical lines right here are to indicate 1 minute in between. Okay, so you will always be able to quickly see whether or not some onset to nadir being the bottommost point, onset to nadir was more or less than 30 seconds, right? So in this one, which is clearly variable decelerations, you didn't even need it to be labeled. You could tell because it's V's. It's very sharp. It's very sharp V's, right? Of course, it'll be sharp because it doesn't take its time swerving around. It just goes down and comes right back up, right? And as far as the time stamps are concerned, you can see it in this first one, for example, the one they labeled from onset to nadir is occurring really quickly. Remember that from here to here is one entire minute, 60 seconds. So then 30 seconds would be like midway. And this dashed blue line they've dropped is less than 30 seconds. Right? And you can always tell, even if this dashed line is very close to the 30-second mark, even if it was on the 30-second mark, it would still be variable because it needs to be more than 30 seconds. Usually it'll be about 40 to 45 seconds. So it's going to be pretty big, crossing over the halfway point, not almost touching the halfway point. That's not what you're looking for, right? It has to go past the halfway point. And if it's gonna, and imagine that if the downward path is supposed to be more than 30 seconds, then of course the upward path is also more than 30 seconds. So the entire V should take more than a minute. But you can see that this V fit within the 1 minute. This V also fit within the 1 minute, here to here. Each of these V's are fitting within the 1 minute. They're not going for more than 1 minute. Right, so then that's how you know that it must be a variable deceleration. These are things you'll have to evaluate very, very quickly when you're doing these questions. So for each one, let's take a quick revision of what we did yesterday. So for variable decelerations, relationship to contraction, not necessarily associated with contractions, hence why it's called variable. Right, as you can see here, this one is associated with this contraction, but this one is not associated with any contraction, nor is this one really. Right? Although you could say that this third one may be associated to this contraction in a slanted manner that is occurring after the contraction, right? But the second one here is definitely not related to any contraction, because if anything was related to this contraction, it would have to be the first one, right? So this one has nothing related to it. Same thing here as well. This one is so far, this V here is so far from both contractions that it's definitely not related to either one of them, right? So that's kind of one of the key things you'll also start seeing and immediately catching variable decelerations. In fact, you don't get many questions on variable decelerations because it's so easy to catch, right? Abrupt, less than 30 seconds from onset to nadir, right? Very quick V's. Decreases more than 15 per minute. So the decrease will go from like 60 to 40, something like that. Right, it's a very sharp drop. You can see this is the sharpest one. This is a very, very deep drop. It came down from 150 to looks like 90. Right, so that's a huge drop. Duration is also going to be a little more than 15 seconds, but less than 2 minutes. Right, so we can definitely see that. Now, why does this occur? So this is not related to contractions. We'll see what the ones that are related to contractions, but it could be due to cord compression, oligohydramnios, or cord prolapse. There's a wide range of reasons why you can get variable decelerations. The book itself mentions umbilical cord compression only. Right? The umbilical cord is compressed, so the baby is having weird fetal decelerations, fetal heart rate decelerations. The baby's basically not getting enough of any of that blood or nutrition, right? From all the things that would, mainly blood, that would come from the umbilical cord. So here they put other things. They wrote in this oligohydramnios and cord prolapse, which are some other answer choices you can pick. For example, for your test, it's very much likely that they won't put cord compression as an answer choice because it's too obvious of an answer choice. It's always the answer. So that would make that question too easy. It's already an easy question the moment they gave you a variable deceleration graph, because you'll immediately catch it's a variable deceleration. Then they have to make it harder by giving you bullshit information in the question stem and an answer choice that you might not have expected. So that answer choice would be oligohydramnios. You'll be able to pick this very easily because the other guys, your early and late decelerations, have very specific answer choices that you can't pick anything else, right? So that actually makes, once again, variable decelerations an easier answer choice. You will definitely not pick the answer choices that you would pick for the other guys, right? And anything else that's left that makes sense to cause the baby to just start, having decreased heart rate, you could pick it, as long as it doesn't fit one of the things for early or late decelerations. So cord compression, oligohydramnios, cord prolapse. If you look at early decelerations, you can see it's symmetric to contractions, right? The deceleration started right when the contraction started. It's called early because the deceleration started before the contraction even reached peak, right? So they're happening together. As soon as contraction has started, the decrease in the heart rate of the baby, the deceleration of the baby's heart rate has also started. And at maximum contraction, you get the nadir of the fetal heart rate. And then as the contraction is ending, you get a recovery, right? So this could be normal, right? This could be normal. This can occur in a normal pregnancy where there's nothing to be of concern, right? But it could also be an indication of fetal head compression. So now, which one is it would really depend on your clinical understanding of whatever the patient is going through. You would have to catch what the patient is going through and base it off of that. Right? We looked at some questions last time. Let me see if one of them was early deceleration as an answer choice. Not that one. No, this is late deceleration in this question. This one was also just, you can see late deceleration because the lines are slanted. Neither of these are early. And then we did a variable deceleration question here. I don't have early deceleration question. I don't have early deceleration question. Yeah. So early deceleration question I don't have here, but if you do ever see it, why would you pick fetal head compression? Well, something else would have to be going wrong with the baby. It could be one obvious scenario that I can tell you about is that maybe the mom has gestational diabetes, so then that would make the baby bigger. If the baby's bigger, then it's definitely possible for the baby to have fetal head compression. It could also be that the mom may be very obese, so then that can also cause compression of the fetal head, and all kinds of stuff like that. They would definitely show it to you in the question that something is not normal. Right? It will be up to you to figure that out and actually analyze that. If everything's normal and there's nothing wrong, then it's just a normal fetal tracing. So early decelerations are not that scary. There's nothing to be that aware of there. Late decelerations, however, are concerning. Late decelerations are basically your contractions are choking the baby, right? And that's what we talked about. So this is a delayed relation to the contraction. The contraction occurs, and then you get a slanted line for where the nadir occurred, because the nadir is occurring after the contraction. You can see that the onset now, compared to early, The onset of the fetal deceleration occurred when the mom had maximum contraction, right? So somehow by contracting, the mom has caused the baby's heart rate to go down. And that's because there's uteroplacental insufficiency, right? You're basically, in a sense here, not really allowing, you're compressing the, very similar to cord compression over here. You're compressing the umbilical cord and not letting the baby get enough blood every time you contract. Every time you contract, right? Nadir deceleration occurs after the peak of contraction, and this is always the only answer choice to pick. Whenever you get a late deceleration, so again, late decelerations are also super easy, right? We see the late deceleration really easily as soon as we look at a graph, and then we figure out what we should be doing. And there's all kinds of weird graphs you can get, which is why the more graphs you look at, the better it gets. In this one of the key things you should have noticed is that there's too many contractions occurring. The contractions are occurring regularly, but there's too many, right? There's no need for that many contractions to occur. And if you keep contracting this often and keep causing decelerations that often, the baby can die. Which is why in this question that we did yesterday, we had to discontinue the uterotonic agents, right? So that was something that was happening in that question. And the more you practice this, the better you get at it. This late deceleration graph is completely different from this first one up here. As you can see, there's only 2 contractions in this, as opposed to the more than 6 contractions that are occurring in that. And you can see how wide each deceleration is. It's so wide that it doesn't even fit the whole deceleration in one graph. Right, so we have 2 incomplete graphs of the deceleration because the parts are not fitting, right? So that's a very, very prolonged late deceleration, right? Where onset to nadir, is extremely higher than 30 seconds. I mean, this entire thing is looking like 1, 2, 3, 4, 5, 6, maybe even 7 minutes long of 7 minutes long to get from onset to nadir or nadir to recovery and whatever, right? So this is your big U right here. Right? All they fit was one huge deceleration here, and then we can't see the others because there's just not enough space. This isn't exactly the real problem here. The problem isn't how wide the U is, though. The problem is that there is a late deceleration, right? They made this graph look really funky just to throw you off. But as long as you can find your U and you can see that the nadir to here is a slanted line, you know it's a late deceleration, that the deceleration occurred after the contraction. And that's related to some kind of uteroplacental insufficiency, right? In this question, it was actually a uterine rupture, right? So of course they can change the question up on you. As long as the answer choice is relevant to a uteroplacental insufficiency, it works, right? If your uterine ruptures, your uteroplacental insufficiency will kick in, right? Because now you're not going to be able to sufficiently supply the placenta, right? Because the uterus has ruptured. But people fell for abruptio placentae, which is a different kind of case scenario, right? So all kinds of ways to get attacked, in a sense, on these questions. But these are not ridiculous questions, and it's definitely something that once you start getting more comfortable with, you can easily handle. Right? So next thing now moving forward is your antepartum fetal surveillance. So antepartum is now the baby's born. In general, antepartum fetal surveillance is used in pregnancies in which the risk for antepartum fetal demise is high. Testing is initiated in most at-risk patients at the 32 to 34 weeks or 26 to 28 weeks if there are multiple worrisome risk factors. The following assessments are made for antepartum risk assessment. Fetal movement assessment, assessed by the mother as the number of fetal movements over 1 hour, so the mom would have to tell you. On average, it takes 2 hours for a mom to obtain 10 fetal movements. Maternal reports of decreased fetal movements should be evaluated by means of the following tests. So now we're concerned when we see decreased fetal movements. So we're going to be looking at the NST and the CST. Before I go on to that, this is also a table related to the same exact thing. The reason I put it here is because it's related. Now, of course, multiple things you look at, you use them in conjunction with each other to evaluate your patient. So this is us using multiple sources of information to evaluate a patient. We're going to be looking at the fetal heart rate monitors intrapartum and how things went there to figure out what's going to be happening in the NSTs and CSTs in the antepartum testing. So if the mom says that she didn't get at least 10 fetal movements in 2 hours, right? That's the 2 hours to get 10 fetal movements. If the mom didn't get 10 fetal movements in 2 hours, then you need to start doing the reactive NST or the non-reactive NST, and then there's the contraction stress test. So let's look at the NST then. The non-stress test, performed with the mom resting in the lateral tilt position to prevent supine hypotension. Fetal heart rate is monitored externally by Doppler along with a dynamometer to detect uterine contractions, right? So this is how we do this, right? The fetal heart rate monitor is going to catch the top line, and the tocodynamometer is going to capture the contractions that the mom is having. See table 2.11-12 for NST interpretation, and we're going to look at that in a bit. Contraction stress test. This is the other one. Contraction stress test. Performed in the lateral recumbent position. So there is a lateral tilt position for the NST, lateral recumbent position for the contraction stress test. Fetal heart rate is monitored during spontaneous or induced contractions. Right? Reactivity is determined from fetal heart rate monitoring, as with the NST. Contraindicated in women with preterm membrane rupture or known placenta previa, those with a history of uterine surgery, and those who are at high risk for preterm labor. Because if you start causing contractions in them, then you're going to get preterm labor. Right? So you don't want to do that. You're just doing a contraction stress test to see how the fetal heart rate responds to the contractions you're causing. Right? Now with the non-stress test, NST, let's see what it means. So a reactive NST is a normal response. Right? A reactive NST is a normal response. You get 2 accelerations lasting at least 15 seconds over a 20-minute period. Right? So figure 2.11-6 is showing you right here, right? A reactive non-stress test. So how does it look? Well, this bottom part is showing you fetal movements, right? So every time the fetal movement occurs, you get the spike. Okay, and when you do a non-stress test, you can see, and this graph here is going to tell us more. So now we're looking at a whole different thing compared to what we looked at yesterday. So you can see that when there was an acceleration rather than a deceleration, before we were looking at decelerations, when there's an acceleration here with the fetal heart rate, that the baby also has movements. Right? They should go together. They should go together. Right? Having 1 or 2 movements here and there randomly is not a problem, as long as every time you have an acceleration, there is a bunch of movement. Right? This means that the only reason the acceleration occurred is because the baby's moving a lot. Essentially, it's like, think about running, right? When you run, your heart rate goes up, so the baby's running and the heart rate went up. Right? That's kind of what's happening here. This is a normal response. Okay, so non-stress test. Description: external fetal heart rate monitoring for 20 to 40 minutes. Normal result is reactive, more than 2 accelerations. Abnormal result is non-reactive accelerations, right? So you want reactive accelerations. You want reactive accelerations, and acceleration with a reaction, right? 2 or more. And we have definitely got more than 2, right? We have a bunch. The number 2 or more or less than 2 is referring to the number of spikes you're getting here. How many spikes did you get? That's what we're counting. So we got like 1, 2, 3, 4, 5, 6, 7, almost 8 spikes. I would count this too, related to this acceleration. Right? A non-reactive acceleration, less than 2. Right? Recurrent variable or late decelerations would also be a really bad thing. If you kept seeing decelerations here, even though you're trying to get accelerations, because they'll tell you in the question that they're doing an NST, then that's bad, right? Because somehow the non-stress test is actually causing the heart rate to go down when you're actually supposed to be going up and having fetal movements, right? So that's problematic. And we'll see what you're supposed to do with that when we get to the practice questions. So you could tell that now what we're looking at, although it was sharing the same graph design, it's related to a whole different thing, right? So now we're working with this kind of stuff. So that was your normal response right here, right? Non-reactive NST. So if you got a non-reactive, right? If it's non-reactive, that's abnormal. Insufficient accelerations over a 40-minute period. Perform further tests. That's the next best step. You're gonna get a question where you did an NST and you got some kind of. So what happens is, and we'll see this, they'll tell you in the question that we did an NST on the patient, and it came back non-reactive. They might either be nice to you and tell you it was non-reactive, or they'll describe it to you, and based off of the description they're giving you, you have to figure out it was non-reactive. Or the third thing they can do to you is they can actually give you a non-reactive NST. So they don't have one here. They don't have one in the book. The book only has a reactive NST. Let me find one real quick to show you guys. Non-reactive NST, and you'll see what it kind of looks like. Not that one. I hate when I find a picture, but it's super blurry. Why does that happen? Wow, there's not really much. Okay, this is pretty good. So let me post it here. So you can see here the spikes that are occurring, right? The spikes at the bottom are the fetal movement. And every time the fetal movement is occurring, there's supposed to be an acceleration because the baby is supposedly running, right? So this is the baby is running. So then of course the baby's heart rate should go up. It's not happening. Right, so then that means that this is bad. This is a non-reactive stress test, non-reactive NST, non-stress test, and that means that you're gonna have to now do further evaluation to see what is the problem, right? That simply this doesn't tell you what the problem is. This simply tells you there is a problem. That's different from what we were doing before, right? With the early, late, and variable decelerations. That did tell us what the problem is, right? Especially the late deceleration. That always told us exactly what the problem is. With the early decelerations, we had to figure it out based off of the other clinical scenarios that the question stem would give us. And with variable decelerations, it was also related to whatever else the question stem gave us. But you would know what the problem is. You would have a high suspicion for what the problem is and be able to order a good test. Here, the non-stress test doesn't tell you what the problem is. Now you have to go check for what the problem is, but it does tell you that there is a problem. So when you get a question where they do one of the three things telling you that this is a non-reactive NST, you will now have to, the question will be like, what's the next best step? What should you do now? Well, you're gonna have to do one of these further tests, a biophysical profile. There's also, we're gonna see later on in other questions that you could just keep monitoring more fetal heart rate. You might have to start doing the delivery. Lack of fetal heart rate accelerations may occur with any one of the following. So to figure out what is the problem, these are the things that could be the problem. It could be fetal sleeping, which is the most common. Usually a difficult question, difficult answer choice to pick because you may not be inclined to pick it. But the reason you won't be inclined to pick it is because the question will tell you all these things that are going to make you think that there is something wrong, right? If the gestational age is actually less than 32 weeks, this gets tested in questions where the mom is not sure about her gestational age, right? So the mom didn't come for regular visits. Mom doesn't really know when she got pregnant, stuff like that. All right, so that's when you can start thinking maybe this is the answer. Fetal CNS anomalies, right? So like the problems with the notochord and all that. So then you would check for elevated AFP, acetylcholinesterase, stuff like that. And then maternal sedative or narcotic administration. Of course, this will also cause the baby to be affected by the sedative, which is why the baby is not having any accelerations. Right? So these are some case scenarios you would have to watch out for. So basically, the only thing the NST does is it causes the baby to have accelerations in heart rate every time there's movement, like this. There's movement and there's acceleration together. When you get this, that's good. The other thing is your contraction stress test. So now they showed this in 2.11S13, so let's go find it. 2.11S13, where did they put that? 2.11S13. I don't see it. 2.11S13. Oh, this table right here. Okay. So we saw, wait, let's just revise one more time. What did we do with the contraction stresses? We had the mom in the lateral recumbent position, and we basically right? We watch fetal heart rate, and after causing, right, either spontaneous or causing induced contractions. And every time there's a contraction, you want to see what's happening with the fetal heart rate. Very similar to what we're doing in the NST. So here you can see a positive CST is where you have late decelerations following 50% or more contractions in a 10-minute window. This is bad. A positive CST is like a positive HIV exam. There's nothing positive about it. That's a problem, right? Positive CST raises concerns about fetal compromise, and you should deliver. Right? Delivery is warranted. A negative CST means no late or variable decelerations within 10 minutes and at least 3 contractions. So now you can see how CST and the deceleration things we were looking at are going together. So this here was supposed to be naturally occurring. And when this naturally was occurring, it was a problem, right? This was a problem. This meant that the contractions were choking the baby. Now, if you could do a contraction stress test where you're actually causing a contraction, and every time you cause a contraction, there is stress, that's bad. And that means that your contractions are stressing the baby, and this might actually require you to deliver the baby. Right? So the two things basically go together. Right? One of them was occurring naturally. The other one is where you're actually inducing contractions to see what's occurring. What kind of reactivity are we getting? Right? Contraindicated in any woman who, if you do the contractions, would lead to preterm labor. Right? So you don't want to do it on such a patient. And that's what they listed out right there. And then the last thing, equivocal CST, intermittent late decelerations or significant variable decelerations, where at this point you wouldn't be sure what to do next. You're not going to be certain. All right. So let's take a look at some of these questions here. First one, 40-year-old woman, G5P0A4. So she's been pregnant 5 times and she had 4 abortions. So now she's on her 5th pregnancy, maybe hoping things go better this time. At 35 weeks, so 40-year-old, that's already a problem. According to step 1, if you're over 35 years age, pregnancy is not recommended, right? So 40-year-old woman, and then this is also looking concerning. She's 35 weeks gestation in, comes to labor and delivery triage because she has not felt her baby move for the past 24 hours. So that's terrible, right? We already saw that in 2 hours, there should be 10 fetal movements. She has not eaten much all day and skipped dinner due to nausea, which is a common thing to occur in pregnancy, right? Feeling nauseous, vomiting, stuff like that. She has 25-pack years smoking history of cigarette use, but has cut down on her smoking during pregnancy. Cutting down doesn't help. Her last ultrasound at 32 weeks gestation showed a fetus in breech position, measuring at the 15th percentile and placenta previa also. So now this is a key thing, right? If she has placenta previa, we cannot do a contraction stress test, because if we cause contractions in her, remember what placenta previa meant. It meant that if you looked inside of her vagina, inside of her cervix, you would get a preview of the placenta. So that means that the placenta is right there where the cervix is. So her placenta is very badly positioned. Coming back to here, this was a step 1 thing. So placenta previa. You see how the placenta is right there? Right? It could be either somewhat on it or completely on it. Both of which are really problematic. Right? This is of course gonna cause bleeding, because now the placenta's blood is gonna come out, and is gonna cause major difficulty in delivering the baby. How are you gonna get the baby out with the placenta's blocking the path? So that is something that you have to be careful with. This is also associated with previous C-section delivery. And remember, you never really want to get a C-section delivery for anyone. If you ever have a relative who's about to get a C-section delivery, you really want to go kind of chime in and be like, what the fuck, why? Why are we doing a C-section? Because unfortunately, in today's time, even in America, hospitals will opt in to do a C-section delivery just so they could charge more. It's a thing. It's undoubtedly a thing. C-section deliveries are also going to require more monitoring. You get 1 more day of hospitalization on the patient, and all kinds of shit like that. If there's no real indication for a C-section delivery, why would you do a C-section delivery? Because once you do it once, if a mother had her first baby by C-section, the second baby will probably be C-section also, 99% chance. So, it's something you don't really need to do at all if it's not necessary. So placenta previa, so we cannot do a CST for her. No contraction stress test. A non-stress test, so that you can do, NST, shows a baseline fetal heart rate of 130 with moderate variability and no deceleration. So that's pretty good. Okay. There are no accelerations after an hour of monitoring despite vibroacoustic stimulation. That is not good, right? So vibroacoustic stimulation basically is stimulation that is supposed to cause some contractions in the mom, and every time there's a contraction in the mom, there should be fetal movement. And this is the NST we're doing. Right, so the NST is going to cause fetal movement and acceleration together. Right, they should be occurring together. If they're not occurring together, then that's a negative or non-reactive NST. So this is bad. And this is bad. So there's no accelerations. That's bad. Tachometry shows no contractions. Part one of a two-part question was that what is the most appropriate next step in her management? What do you do now? Well, we talked about this, right? We said it. We said it right here. If you get a normal response, you're good. Nothing to worry about. If you get a non-reactive NST, what was the problem here? This simply told you that there is some problem, but it didn't tell you what is the problem. So now you do a biophysical profile. That was the answer here, right? Biophysical profile. If you ever get a patient who's getting an NST done and there's no accelerations after trying to cause accelerations in fetal movement, then now you need to do a biophysical profile. A biophysical profile is like this. Okay, so you have your biophysical profile component and score. The non-stress test 0, amniotic fluid volume 0, fetal movements 2. This is showing you an example of what it looks like for this question. Okay, and how do you actually do a biophysical profile? This is the chart. This is the same chart. So I put both questions here because it's relevant at this exact moment, right? So this is a sample related to this question, okay? And this is what it actually looks like. So basically how you score it is you do a biophysical profile, you check the NST, non-stress test, reactive fetal heart rate monitoring, yes or no, you know, amniotic fluid volume, how many fluid pockets are there if there's a single fluid pocket, or if there's amniotic index of more than 5, fetal movement, more than 3 general body movements, hopefully, fetal tone, and fetal breathing movements, right? These are all things you check for, right? Performed continuous observation for more than 30 minutes, right? So this is something you would have to do for this baby. Table for antepartum fetal surveillance was given, which is this table right here, okay? So biophysical profile, non-stress test plus ultrasound assessment of the following: amniotic fluid volume, fetal breathing, fetal movement, and fetal tone. 2 points per category if normal, and 0 points if abnormal. This patient already has 0 points for the first thing, which was the NST, right? And if you have 0, 2, or 4 points, it's abnormal. So that's when you know something's going to be wrong. She presents with decreased fetal movement, a subjective and non-specific symptom that may be benign or ominous. A NST is performed to assess fetal status and identifies fetuses at risk of adverse outcomes. During an NST, the heart rate of a well-oxygenated fetus rises with fetal accelerations, like this. A reactive NST has a high negative predictive value to rule out fetal acidemia. A non-reactive NST requires further evaluation with the biophysical profile or a contraction stress test, the CST, both equivalent in assessing fetal status. However, for her, you could not pick contraction stress test, and that probably was an answer choice. Right, that's why I wrote choose based on availability and contraindications. You choose based off of availability, what test is actually available to you right now in your hospital or clinic, and you choose based off of contraindications. For her, we could not do a contraction stress test because if we induce contractions in her with her placenta previa, we risk preterm labor. Okay, so now there was a part 2. An ultrasound confirms an anterior placenta covering the cervical os and the fetus is breech. Over 45 minutes, there are 4 fetal movements, right? So we wanted more than 3, right? So now you can start filling out your table. Now you don't really need to have the table. You just need to have an understanding of what's needed on the table. You're not really going to make this table and fill it out because you're not going to remember all of it. But what you do need to remember, in a sense, you will remember all of it, because what you do need to remember is all the things you actually looked for. But there's only so many things you can look for in a fetus, right? If a pregnant woman is there and she has a fetus, what are things you actually can look for in there? How much amniotic fluid is in there? How much is the baby moving? Does the baby have any tone at all? Is the baby breathing? Right? These are the only things you can really look for. I mean, what else would actually be something you would look for that would indicate a biophysical profile of a baby? So they are now telling you the things that will go on the table. So they told us that there are 4 fetal movements. We needed more than 3, so that's good. So we're gonna give it 2 points there, right? And then they tell you that there are 3 flexion or extension events, no fetal breathing movements, so no fetal breathing, so that's 0. Oh, and the flexion and extension events tell you that there is fetal tone. So as long as you get more than 1 episode of flexion extension, you're good. So we're gonna give 2 points here. Amniotic fluid index of 1.5 with a single fluid pocket measuring 1.5 by 1 centimeter. That's bad too. That's not good enough. All right, so we're gonna give 0 here because it needs to be more than 2 centimeters or an index of more than 5. She doesn't have that. Right? What is most likely cause of her biophysical? Oh, and this was already 0 because we did the non-stress test and it didn't work well. Right? Non-reactive. So then she has 4 points. That's not enough points out of the 10 points you would get. Right? So maximum score is 10. 0 is abnormal. 2 for each normal component. When you get only 4 points, 0, 2, or 4 points are considered abnormal. Now, would you actually be able to do this table in your mind and fill it out? Hopefully, yes. That's kind of what you're trying to get to. Right? You want to be able to do this so you can answer these kinds of questions. But if you couldn't, maybe you don't feel like studying this, maybe you're running out of time, step 2 is very soon, whatever the reason might be. Or maybe you're actually, you did your studying, you sat down for the test, you forgot the table, or you're blanking out, whatever the case scenario. As long as you're there and you can look at these things, you should be able to figure out what's happening. Because you see, you don't need to memorize the table. They're giving you each of the things. So each of these things indicate something. The 4 fetal movements indicate a fetal movement. The flexion and extension indicate a fetal tone. So you didn't need to remember fetal tone as one of the things you're going to look for. They're telling it to you. Flexion and extension, that's the thing about tone, whether or not you can flex or extend. No fetal breathing, so you know now fetal breathing must be on the table, right? And then amniotic fluid index, that's the amniotic fluid volume, that's also on the table. So you don't need to memorize the table. When they start listing out all the things for you, you'll know it goes on the table. Whether or not you can remember these specifics is also not relevant. The specifics are pretty big. It's not like a very, very specific. For example, fetal movements, as long as you have 3 or more. Right, so obviously 1 or 2 fetal movements is not that significant. You should have, as we said, 10 fetal movements in 2 hours. So then in 1 hour you should have at least 5 fetal movements, right? So 3 or more. And this person has 4 fetal movements, which sounds like a pretty good number, right? They said that they did it for 45 minutes, by the way. Right? So in 1 hour you're supposed to have 5 fetal movements. In 45 minutes they already got 4, so that's pretty good, right? 3 flexion extension, that means there's tone, there's no breathing, the fluid is very low. So you can actually definitely do this scoring very easily. You don't need to memorize anything. The question itself is telling you what the parameters are. So now they ask you, after all of that biophysical profile stuff, what is the most likely cause of her biophysical ultrasound finding? Well, when we look at her biophysical ultrasound, that alone doesn't tell you anything either. Think about it. Look at this biophysical profile. We just scored it. Does it tell you what the problem is? It doesn't. The problem was actually very evident without even really doing the biophysical profile, and in a real life clinical setting you wouldn't need to do it. It was the one thing that was really critical about her placenta previa. So the reason that her baby is not moving is because this placenta that is malpositioned must not be functioning well. Think about it. This portion of the placenta that's hanging out, and any portion of the placenta that's hanging out, is not going to be getting adequate supply from the mom to give to the baby, right? Normally, the placenta is supposed to be way up here, right? That way it can take a lot of shift from the mom and give it to the baby, right? When you put the placenta all the way down here, there's not much you can steal from down here. All your organs are up here. Your intestines and everything, all the stuff, the girth of the things that the mom can give the baby are up here. So by putting the placenta down here, it's a very dysfunctional, weak, bleeding placenta, right? So that was the only problem. So placental dysfunction was the answer. Now they were real assholes with this question just to teach you something, of course. This would never happen on the real step. To teach you, they also put the answer choice placenta location, which isn't exactly the wrong answer, right? But remember how STEP is all about the best answer choice, so one is definitely better than the answer choice. Placental location wasn't the true problem. The true problem is that there's a placental dysfunction. Why is there a placental dysfunction? Is because it's located in a bad place. So you see how both answer choices are viably correct, arguably correct answer choices, but placental dysfunction is the true reason why we have a problem. Placental location is not the true reason the baby's dying, because your placenta could be located where it is and be, if it's functioning fine, then who cares, right? So it wasn't just the location that was the problem. The real problem was placental dysfunction. So if you're ever in any kind of a problem like this where you have to pick between two dumb answer choices that both seem viable, truly stop and think, which one is the root problem? The root problem here is the placenta is not working. Not because we care about where the placenta is. The placenta is not working. Why is it not working? Well, it was because of the location, but the real root problem is that the placenta is not working, because it could be located there and working. If it was working, then we wouldn't care about the location, right? So placenta dysfunction, and what is the placental dysfunction causing? It's causing oligohydramnios. We can see that of all the zeros that she got, the one zero that is really problematic is not having enough amniotic fluid, right? She has oligohydramnios, where her single deepest pocket of fluid is less than 2 centimeters. We got 1.5, right? 1.5 by 1, right? The single fluid pocket measuring 1.5 by 1. That's less than 2 centimeters. And her fluid index is less than 5, significantly low, right? So those are all problematic things that you cannot work with, right? So that oligohydramnios is, of course, going to cause issues in the baby. What is the most likely cause of her biophysical ultrasound finding? Oligohydramnios. That could have been an answer choice also, okay? But placental dysfunction, they did this so they could teach you the difference between understanding what is a better answer choice and what is not. She has a really bad BPP of just 4 out of 10, as we calculated, indicating fetal hypoxia due to placental dysfunction. So she requires prompt delivery due to risk of fetal demise. Placental location is not associated with an abnormal BPP. It could be located wherever the fuck it wants to be located, as long as it can function, right? So very good question. Teaches you how you're going to use the NST, teaches you how you're not going to do a CST in a patient when it's contraindicated. It teaches you that when the NST is non-reactive, the next best step is to do the BPP or the CST, and we chose BPP for obvious reasons here. And then it teaches you how you evaluate a BPP, and the fact that you don't need to memorize the table components are given to you when they tell you what they found, and you can score it with zeros or twos. All right, it's a great question. Make sure you revise that question if you're still confused about any of it. As always, of course, shoot me an email if you need anything. Now let's take a look at this question. This one, again, the answer is uteroplacental insufficiency, which we know is related to, as we saw already, your late decelerations right here. Late decelerations. Every time there's a contraction, you get a deceleration because you're choking the baby. 28-year-old woman, first pregnancy, 41 weeks gestation. So she's at a good age. It's her first pregnancy, and she's very close to delivering. If anything, she's a little late. Comes for antepartum fetal surveillance. She has had less fetal movement than usual, but no abdominal pain, leakage of fluid, or vaginal bleeding. Now, at this point, I would hope she would get leakage of fluid. She needs to get the rupture of membranes and deliver already. She's 41 weeks pregnant. It's about time, right? But we're glad that there's no bleeding, and I guess it's good that there's no abdominal pain. Blood pressure's fine. Her pre-pregnancy BMI was super high, so she's very obese. We talked about this just a little while ago, that one of the reasons you could get fetal head compression, I was saying it, right? Fetal head compression could occur because of obesity. Fetal head compression could occur because the baby's too big, maybe gestational diabetes. And obesity could also cause uteroplacental insufficiency, right? Because you could compress your placenta. And she has gained 44 pounds during the pregnancy. We saw earlier that the normal amount of weight gain during pregnancy is about 25 to 30 pounds max. A pregnant woman can gain 25 to 30 pounds. She gained a lot more because she's obese, so she put on a lot more than someone else normally would anyway, which has been during her pregnancy, which has been uncomplicated otherwise. So now we're going to do an NST. Why are we doing a non-stress test? We're doing an NST because she has less fetal movement. Anytime that happens, you do an NST. Why do we do an NST? Because that NST is going to cause fetal movement every time we do the stimulation. The non-stress test shows a baseline fetal heart rate of 140, moderate variability, and no accelerations. No accelerations. So that's bad, right? That's a non-reactive non-stress test. A reactive one is supposed to have accelerations with fetal movement. No accelerations in 40 minutes. That's really concerning. So what do we do now? Next step was to either do the CST or BPP, right? Because we got a non-reactive NST, but a non-reactive NST doesn't give us an answer for what is the problem. 2 contractions are seen on the Toko dynamometer. An episode of fetal heart rate decrease to 130 began after the peak of a contraction and lasted for a minute. So this is telling you now what they're seeing on the fetal heart rate tracing, and they're seeing that there was a decrease, which is a deceleration, after the peak of a contraction. That is a late deceleration. Ultrasound shows a fetus in the cephalic presentation, a loop of umbilical cord near the fetal neck, an estimated fetal weight of 35th percentile for gestational age, and a single pocket of amniotic fluid that is not good enough, right? So this is basically leading on to, obviously, the BPP, and of course, they tell you now the BPP results are shown. Boom, right? So you see the BPP. Non-stress test was, of course, a 0 because we saw there's no acceleration. Amniotic fluid volume is a 0 because it's less than 2 centimeters. Fetal movements is occurring, so we give it the 2. Fetal tone is apparently occurring, so we get a 2. We don't know this is occurring. They're just telling us that now in the table. They didn't tell us this in the question stem. So fetal movement is there, fetal tone is there, no fetal breathing. So this is 4 points. That's bad. That's really bad. What is the most likely cause of the BPP results? Well, they described to you the contractions that are occurring, peak of contraction leading to a deceleration. They described to you a late deceleration. Late deceleration is uteroplacental insufficiency. Right? So you see how they made this kind of question kind of a mixture of everything, the NST, the BPP, the fetal deceleration, and then the question was actually just about the fetal deceleration, not anything else, right? The fetal deceleration, the late deceleration that's occurring is a sign of uteroplacental insufficiency. Always. It's a 1-to-1 answer choice. Decreased placental function is due to increased placental vascular resistance caused by age-related placental changes in late-term pregnancy. She's in late term. This leads to reduced placental perfusion during contractions, resulting in intermittent fetal hypoxemia. NST presents that as late decelerations that gradually nadir after the peak of contraction. This may progress to chronic fetal hypoxemia, causing CNS suppression and fetal demise. To prevent this suppression, blood is distributed to the brain rather than peripheral tissue, resulting in decreased fetal activity. In the kidney, this may lead to oligohydramnios. The abnormal BPP suggests imminent risk of fetal demise and delivery is indicated. Right? Another question could have been, what is the next best step in management? Immediate delivery. Right? That's another question. I could put the same exact question stem and then change the final thing. The last sentence would now say, what is the next best step in management? Next best step in management will be immediate delivery. Okay? And this is great. This is now showing you what you're supposed to do. Right? Now we've learned obstetrics. We know now what we're supposed to do with a pregnant woman. In step 1, we learned about starting folate before you're pregnant, looking for certain, avoiding certain contraindicated teratogenic medications. Right? We learned about what are some things that could be occurring to the placenta, like the placenta previa stuff. Right? This is all they really taught for step 1 pregnancy. And that was it, because there was really not much else. Some of these things, and then of course ectopic pregnancies. We learned about poly and oligohydramnios, but we learned about these things more so in relation to renal, if anything. And we learned about this kind of a pregnancy, the hydatidiformal, but then there was really not much else. Just general, very basic things, nothing actually related to the world of obstetrics. So now we're seeing in the world of obstetrics how we use fetal heart rate monitoring, ultrasounds, and contractions to really figure out if the baby is doing well, right? And that's what all these practice questions are helping you master. Okay. So that's your biophysical profile, your amniotic fluid index, all the other things that we've been looking at right now in different questions. Right? So now the amniotic fluid index can often lead to its own question, right? To its own question. In fact, we see that here too. They put it in the explanation that there's going to be oligohydramnios. Right? This was also over here. So that's another thing you could get as a answer choice. They could be like, what is a complication that may occur later on, or a complication that the baby is at risk for? the baby is at risk for a complication of oligohydramnios. All right. So key thing to watch out for, very critical. All right. That can be something. So here they're telling you amniotic fluid index. It's oligohydramnios if it's less than 5, and it's polyhydramnios, too much, if it's more than 24. But you don't really need to wait for 24. If it's more than 15, that's also something you start considering, like, okay, what's happening here? You know, but more than 24 is where you're supposed to, like, for sure, at least for step purposes, pick the answer choice related to polyhydramnios. So now you have to know from step 1 things that can cause oligohydramnios, and then things that oligohydramnios can cause. Both. Right? What are things that can cause oligohydramnios? Preeclampsia, abruptio placentae, because of the placental abruption causing bleeding and everything coming out. Uteroplacental insufficiency, which was our question right now. Renal anomalies, of course, which is like the things we learned in step 1. And use of NSAIDs, because you lose your prostaglandins. These are things that can cause oligohydramnios. And then if you have oligohydramnios, what can oligohydramnios cause? It can cause meconium aspiration, because the baby is supposed to drink the amniotic fluid. If there's no amniotic fluid, the baby's going to poop and eat the poop, which is not going to be good. Preterm delivery, of course, because there's not enough amniotic fluid. And umbilical cord compression, once again, of course, because there's no amniotic fluid. Remember that amniotic fluid also functions as a cushion for the baby and the umbilical cord to freely float in without being squeezed. Okay? So, again, these are things that are not too hard to understand. And when you see these things as answer choices, it should ring a bell like, yeah, that's related to oligohydramnios, and you pick that answer choice. If you have polyhydramnios, then now you have too much amniotic fluid, right? So now you need to figure out what causes polyhydramnios. Well, esophageal and duodenal atresia, because if you cannot swallow your amniotic fluid as a fetal baby, then you're going to just have amniotic fluid stacking up. Anencephaly, once again, anencephaly is related to the frontal portion of the head development. They cannot swallow amniotic fluid. Multiple gestation, congenital infection, and diabetes can also all cause polyhydramnios from different reasons. The first two are because you couldn't swallow the amniotic fluid, so it's stacking up. These other things have their own pathophysiologies that you don't need to concern yourself with too much, but you can definitely look it up if necessary. So these are all case scenarios of polyhydramnios. And if you have polyhydramnios, what does polyhydramnios cause? Polyhydramnios, too much amniotic fluid is going to cause fetal malposition, because remember that it's supposed to be a cushion, not a swimming pool. In a swimming pool, the baby can just start turning around, right? A cushion is just going to let the baby sit comfortably. But now there's a whole swimming pool of amniotic fluid where the baby is just going to be floating mid-air. So fetal malposition is usually the main thing that gets tested here. The other things, preterm labor, preterm rupture, and umbilical cord prolapse, not really. Right? It's just fetal malposition. That's the biggest thing we care about. We need the baby to be nice and vertical so it can just come out. Right? If the baby becomes horizontal, that's really bad. How are you going to get the horizontal baby out? Right? And if the baby's the other way around with the legs down, that's also a little problematic. You want the head to come out first and everything else after. So that's kind of what we're going to be analyzing as we figure that stuff out, right? And then the last thing here is your obstetric analgesia and anesthesia. Now, every time you read a question, if a patient is pregnant and she's having a lot of pain, you might see that they did epidural anesthesia for the mom. When they do that, you underline that, highlight that on your test. Okay, we've done it already in some questions we looked at. Sometimes it might actually be related. So far, we haven't seen a case scenario where it was related to the anesthesia. Uterine contractions and cervical dilation result in visceral pain, T10 to L1. Descent of the fetal head and pressure on the vagina and perineum result in somatic pain, pudendal nerve, S2 to S4. In the absence of a medical contraindication, maternal request is a sufficient medical indication for pain relief during labor. Okay? Transient hypotension is a common complication and does not require treatment unless there are signs of vasomotor shock caused by inadvertent injection of the medication into dural space. This I have seen a question on. Right? So when you do epidural anesthesia, it was possible that you didn't just do it epidural, but you actually put it into the dura. The injection went into the dura. It's supposed to be epidural. When you read that, just remember epidural. Then you're like, okay, but did you do it epidural or did you put it all the way through? Because if you put it all the way through, then you put the medication into the dural space. which means that now it's past the dura, which means it can go to the brain, right? Epidural would have just affected the area where it was, but now it's through the dura, it's going to go inside, it's going to go up the brain, it's going to cause vasomotor shock. A little bit of hypotension is fine, but vasomotor shock is not fine. Right? So if you get a patient with a little bit of transient hypotension after the epidural anesthesia, not a problem. You don't need to do anything. Continue. Epidural anesthesia can cause postpartum urinary retention. Urethral catheterization is diagnostic and therapeutic. So this is a very easy one-on-one question. You get a patient, they did the epidural anesthesia, the baby was born, baby's doing great, everything's okay. Then all of a sudden, next day, the mom is complaining she hasn't urinated in over 24 hours. What the fuck? Well, super simple. Doesn't matter what the fuck caused the lack of urination. Just do the catheterization, put a tube in there, she will pee. Right? Not only is it diagnostic, but it's therapeutic. And it'll just let the pee happen. All good. She'll be fine. It's just a temporary thing that's occurring due to the anesthesia. Remember that you're affecting the S2 to S4 area, and there's a lot of nerves there that affect your urinary, your urethral sphincter, your other sphincters, other things, bladder contraction, right? So all of that. So it'll go away as the anesthesia weans off. No big deal. But of course, it's really disturbing for the mom who just delivered to not have had peed for 24 hours, right? So you need to do this. So very one-on-one answer choice here. Super simple question. Absolute contraindications to regional anesthesia, epidural, spinal, or combination include the following. So these are people you would never give anesthesia to, even if they're asking for it, right? Because here they said the only reason a good enough reason, a sufficient enough reason to do it is if the mom requests it. But you have to deny it and help her in some other way. If she has refractory maternal hypotension, because remember, giving the analgesia actually caused transient hypotension. So if she already has maternal hypotension, she can become too hypotensive. If there's maternal coagulopathy, maternal use of once daily low molecular weight heparin within 12 hours. If she's been on heparin within 12 hours, you cannot give her analgesia. Very rare for a pregnant woman to be on heparin, but if it does occur, if a pregnant woman does need anticoagulation, you do use heparin, right? And if you use heparin and then during the labor point she's getting pregnant, it's only been under 12 hours since you used the heparin, you cannot do obstetric analgesia. Untreated maternal bacteremia, don't do it. This is actually very key because it'll also start masking the fact that she still has bacteremia. She won't have any pain, right? So you won't know if she's supposed to have pain because of the infection. Skin infection over the site of a needle placement, don't do it. Don't give her analgesia. An elevated intracranial pressure caused by a mass lesion, either a hematoma or a tumor, don't give her analgesia. These last three cases are all cases where you don't want to hide the pain. You don't want to hide pains that are non-related to pregnancy. These bacteremia or mass lesion things, you don't want to hide these pains, because as long as those pains are visible to you, you know you still need to resolve them. If you start masking critical pain things, she's going to continue having more problems later on, right? So these are basic things, but not really something you'll really get many questions on. The real questions will be on these other things. Most commonly, you'll probably see this one right here. Epidural anesthesia was done. Next day, the mom's not peeing. What do? Just put a catheter. She'll be fine. Okay. So we're done with that. Next video tomorrow, we'll move on to medical complications of pregnancy.